Fabulous. Well, it's just after the hour, and I'd love to get started. We've got a fabulous didactic with a good amount of panel discussion built into it. My name is Willie Baker, and I chair the ED Admin and Clinical Ops Committee. And there are a number of members of the committee who put together this didactic, particularly Dr. Sanchez and Dr. Gavin. And we're very, very excited for this because I myself am excited because I spend a lot of my career in what I call fire suppression. And I think this panel will help you to navigate balancing the fire suppression portions of your day with moving forward with proactive efforts. So Leon, would you like to get started?
So I was gonna kick us off. I think, good afternoon, everybody. Nick Gavin, Vice Chair of Clinical Operations and Emergency Medicine at Columbia. We're co-hosting this. I'm co-hosting this with Dr. Leon Sanchez. Leon, do you want to introduce yourself?
Oh, sorry, I'm Leon Sanchez. I'm currently the chief at the Faulkner Hospital, and had a long career in ED operations.
And the idea for this panel actually came out of a committee discussion a few years ago, where Leon said something that I thought was really important to recognize, which was the what he called the assistant professor trap for operations leaders in emergency medicine, and kind of a difficulty that folks find in progressing academically. So we wanted to bring together 3 leaders within emergency medicine who are at various stages of their career, and talk to you about their experience, what they've found to be useful and helpful as their career has progressed. So we want to get to them. So I'm going to very quickly just introduce the 3 of them. The person that will be joining us, that we're working on the technical difficulties, is Dr. Leon Haley. He's a professor of emergency medicine, vice president of health affairs at the University of Florida, and serves as the dean of the College of Medicine in Jacksonville. Second is Dr. Josh Joseph, who's assistant professor of emergency medicine at Harvard Medical School. He leads the operations interest group of SAEM, and Josh has published widely in the ED operations space. And finally, and last alphabetically, is Dr. Jen Weiler, professor of emergency medicine at the University of Colorado, serves as the chief quality officer for UC Health in the Denver metro area. I don't see Dr. Haley as yet, so we'll get started with Drs. Joseph and Weiler. Drs. Joseph and Weiler, I was hoping we could start by just having you introduce yourselves, tell us a bit about your story, perhaps share some strategies that you've used to remain academically productive while advancing in a leadership capacity. If you could also comment on mentors, what makes a great mentor, what makes a poor, inadequate mentor, and if you could do something differently early in your career, what would you do differently? Dr. Weiler, maybe we'll start with you to kick us off here.
Sure. Thanks for the invitation today. I'm really honored to be here. Again, I'm Jennifer Weiler, and I am the Chief Quality Officer at UC Health here in Colorado. We're the largest and only academic health system in Colorado. We have 13 hospitals and serve a couple of million patients here in the Rocky Mountain area. I previously served as Executive Vice Chair of Emergency Medicine for about a decade at the University of Colorado. So first you asked around briefly a story. I got interested in ED operations early in my career. Actually spent a little bit of time between college and medical school in New York, which is very different from I was a Colorado native and left for about 15 years. And was a philosophy and molecular biology major and had zero exposure to finance. But living in New York City, it's inevitable, as Nick I'm sure can tell you, That's all anybody wants to talk about in their free time. So got a little bit of a bug to understand a little bit more, economics. And when I joined medical school, it became pretty clear to me when care delivery didn't make sense. If you ultimately went back and looked at what were the drivers of performance, they were often financially motivated. So went on to get an MD MBA and then served in a number of operational roles, starting out as most to do as an assistant medical director, and then moving throughout my career, which I'll be happy to talk later about, answering questions if it's important. I had a couple of thoughts around strategies for being academically productive, and I guess I'm excited to say that our board just approved my tenure, and I got the letter today, and so I'm lucky now to be, I think, one of a few folks in emergency medicine who are tenured professors, and probably can count on one hand women who are tenured professors. And my hope is that sessions like these will help inspire others and help them to navigate to become academically successful. So I had a couple of thoughts regarding strategies around becoming or being academically productive throughout your career as an operations, quality, safety, administrative leader. And the first is around goal setting. I think that's really important. And we actually expect our faculty to generate scholarship, which we define as ideal state peer review publications, and ask them to try to publish 1 to 2 manuscripts per year. It's easy to say, and as we all know, really hard to do. And especially if you're not in the traditional investigator track, where there's the cycle of grant funding in addition to manuscript development and scholarship. That the focus is, we tend to focus more on manuscripts as the output as opposed to the cycle of attaining grants, but I'm happy to talk about that also. So that was one, setting goals. The next is around mentorship, but I think it's also around this idea of co-mentorship, and that's picking collaborators deliberately. I think it's really an important strategy to partner with others who expand your skill set. So if you don't have expertise within, let's say, statistics or traditional data analytics methodologies, add that person to your core team of partners. Often I find traditional investigators, and I mean those folks who are going from their career faculty awards, so K to R's, and making those transitions. They have spectacular ideas. They don't know how to lead teams typically. That's a skill set they learn as associate professors. And they are learning to build out their research teams and their labs, especially in this translational science space. And we are, as operational leaders, are great partners for them because they don't have time to put their head down and actually do the implementations in that clinical translational space. So partnering with folks who are in that clinical translation space where you are their clinical operator who can actually implement their solutions is a great space. And then they can help to backfill where you may have gaps around your expertise in either successfully achieving grant funding or in the data analytics and analysis space. My third suggestion is around picking scholarship projects deliberately. So I think often, especially in this clinical operations space, we tend to focus on projects, at least early on in your career, instructor assistant level, of projects that are very time consuming, but may not be of high academic value. And that might be picking a non-peer reviewed journal to spend your time publishing versus peer reviewed locations or scholarship. Others may be focusing on developing case reports as opposed to other broader areas of scholarship. I think one nice strategy that I absolutely leveraged in my career is being the lead author on white papers or consensus papers, where you're working with other thought leaders. It's fun, it's interesting, and it helps you to do your day job. But then taking the lead on developing the scholarship on that actually becomes important from an administrative and operations perspective. If you're the person who helped write the paper on how to do something at your local institution, that gives you a lot of street credit to be able to implement processes. And ultimately, really, you know, the gold standard are randomized controlled trials, but those are hard to do in operations. And so again, depending on how you picked your collaborative partners, that may or may not be something that you can seek to implement. But I find that those are very hard because usually if we think there's the right way to deliver care, we don't want to wait and do an RTC to be able to prove that. We want to do these tests of change, and usually step wedge designs are the ones that are more utilized. My next suggestion is to project manage your research team. When you think about this is around mentors and collaborators, but really have shared expectations around deadlines, goals, and deliverables. And nobody likes to think about this, but I would, and I see this a lot as a, well, personally, what I would do differently if I had to do it again, and what I see as a flaw in how sometimes my mentees approach this is not having the uncomfortable conversation about what happens if this doesn't go the way we plan. So it's uncomfortable to pull people along in a research project who aren't contributing. It becomes uncomfortable not to talk about contribution, including first author, senior author, and role in a project early on. And that can really lead to some hurt feelings and relationships if you don't have that conversation early on. It's awkward in the beginning, but when you learn to do it, people are really grateful that it happens. My last tip is early on in your career. So in that associate professor stage, being really deliberate about applying for institutional awards. Typically, they're easier to achieve, and maybe even departmental awards. Typically, they're easier to achieve. They tend to be in this, quote, QI space. You can partner with other mentees or mentors where they may have access to funding, residents or medical students that you can act as the mentor to them, and there's some academic opportunities to develop your role as a mentor and to practice doing that. And most department chairs would be really, I think, they would be welcome the idea to set up a grant internal, couple $1,000 for quality, safety, and operations related work if you just ask them. And then suddenly you can apply for the award yourself and be an awardee, get academic credit for it. And then also, I think it teaches our chairs about how to think about operations and quality in our space as one that we can be still academically productive. So you got to do some self-advocation, I would recommend, with your chairs. And with that, I'll end and defer to my other panelists, but just a couple of thoughts.
Thank you so much. Dr. Haley, maybe we'll turn to you next. So just doing intros, telling a bit of your story. How have you remained academically productive while growing as much as you have? And what do your mentors look like?
Great, thank you for the opportunity to talk a little bit. And I would certainly echo a lot of Dr. Weiler's thoughts, but I'll give you a little bit of my story. So trained in emergency medicine at Henry Ford Hospital in the early 90s. And actually very early on in my career, really felt like I wanted to go into healthcare administration / leadership. Thought there was a wonderful opportunity to use our expertise in emergency medicine to, quite frankly, what I saw as sort of healthcare operations gone wrong. Taking care of patients obviously in the hallway and, quite frankly, not doing a very good job of it, but also thinking about throughput and flow. So I just became very interested in how healthcare and hospitals worked. I decided to formalize that and get a master's degree in health administration very early in my career. So I am one of the people that advocate sort of as you develop your operational niche, if you can and have the opportunity and can afford it, given the timing, certainly a master's degree to support some of the sort of operational analytics and additional needs, understanding the business and finance of healthcare would certainly be something that I would recommend. So I had the opportunity to do that very early at Henry Ford, and I got that degree from the University of Michigan. moved on to Emory University as a faculty member, originally, interesting enough, in the Department of Surgery because emergency medicine was still a division at that time, ultimately became a department. And I took over actually as the chief of emergency medicine. So at a pretty still young point in my career, just fast forwarding, I'll come back to some of the operational pieces. As I got more interested in operations, started to expand the footprint into more hospital administration, hospital leadership, became the deputy chief medical officer for the hospital, also became the vice chair of emergency medicine. And then after doing all of those for about 17 years, I moved over to the dean's office at Emory and became the Emory Executive Associate Dean. And was still doing obviously clinical work and still doing research and education as part of the department, but really now sort of full-fledged in medical school operations, medical school leadership, although my focus was really on the things that we did for Emory at Grady. And then just about 5 years ago, was offered the opportunity to move to Jacksonville, Florida, where I'm a faculty member of the Department of Emergency Medicine here. But really my full-time job is I'm the CEO of UF Health. So I've completely moved into hospital leadership and hospital administration, run our 2 hospitals. I'm also the dean of our regional medical campus. So we have a 2-year campus in conjunction with the University of Florida in Gainesville. But we have our own separate residency programs, faculty, physician practice plan. And as part of the physician practice plan role, I serve as the chair of our board. And so that helps to help direct our enterprise, which is 30 plus clinical sites and across 5 different counties in 2 states. So I've sort of moved completely into healthcare administration. I'm still clinically active and actually serve from an emergency medicine perspective, still on the American Board of Emergency Medicine. So just real quick, some of the strategies I took very early on, and I will echo a lot of the points already made. I think mentorship and identifying mentors are really critical, I think, very earlier in your career. And I think as a reminder, they do not have to be in emergency medicine. They can certainly be in another clinical department, or in my case, I'm very early finding a hospital leader that I wanted to partner with. And so my mentors have been those in emergency medicine, but from a clinical standpoint, Kurt Kellerman was the chair of emergency medicine at Emory University and was a very powerful mentor for me and really helped guide a lot of the early writing and paperwork that I was able to participate in. And he was good by, pushing me and making sure that I was part of a paper, doing the work to support that, obviously. And then also having mentors in hospital leadership to, pique my interest in hospitals. So as a reminder, your mentor does not have to be in emergency medicine and certainly can be outside of emergency medicine. I heard a word earlier on partnerships, and I think that's the other piece of the equation. And who are your partners? So in the operation space, as you think about clinical operations, maybe your partner is somebody in trauma surgery, for example. So I've written papers with the trauma surgeons around throughput and flow as it relates to trauma care. Maybe it's somebody in internal medicine as it relates to, in our case, a care management unit, which was really sort of one of the early stages of the observation care. Who else outside of the organization. So we were blessed in Atlanta to have a number of other universities we could partner with in terms of Morehouse School of Medicine, Georgia Tech. And so just identifying and finding people outside of, healthcare, and sometimes outside of even, your own university to partner with. And so I tried to figure out, are there partners that we could work with? And quite frankly, I did a lot of cold calls, right? Just, not knowing anybody sometimes, but just, sort of reaching out to the department, and sometimes I was successful, sometimes I wasn't, but it was okay to get a no. But I think creating partnerships, clinical partnerships, administrative partnerships is important. That's absolutely critical. And I would say the other piece for me very early on was, as I was thinking about funded research, think about atypical partners. I did not feel that I was going to go down the NIH pathway, but who else could fund, some of our operation research? So very early, we were, writing on paper and whiteboards. And so I really felt like we needed to move in the space of having an electronic health record. And so at a suggestion from one of our government relations folks, I approached the Department of Defense to help fund really getting us an electronic health record. They asked for a research project. So we built a research project around, an electronic health record and really studying traumatic brain injury, partner with another faculty member in the Department of Emergency Medicine to write that grant, but then basically took an operational need, which was getting to an electronic health record, getting off of whiteboards and paper, partnering with Department of Defense, and then partnering with another faculty member to write a research grant. I used the Healthcare Foundation of Georgia to help us study our case management unit, Robert Wood Johnson. So, I think we oftentimes get caught into, NIH and some of the big federal grants, but there may be certainly local grants. I think you heard previously, is there something institutional you can think about? Are there other funding sources? Is there a foundation you can connect with? So I was always, and even now I can tell you, we work with our development team around who are the atypical foundations that we can, partner with and potentially think about a grant. And so at this point in my career, sort of fast forwarding real quick, some of the work that we're doing around health equity, we have an organization in our hospital called the Urban Health Alliance, where we really focus in on health equity, health disparities, and we've been able to partner with a number of different foundations on our projects to really support our work in health equity and getting, quite frankly, patients taken care of and access to food. And I would say, I know we want to spend some time for questions. I'd say the last thing I would sort of do over again is, I've decided very early in my career to do administration. So I don't think I ever dropped into what I thought my clinical niche was going to be. So I would still recommend that, within our specialty, think about what's the clinical thing you really want to be the expert in, right? Because that actually does also play into the grants and the papers that you write, and also plays into the partnerships. And of course, from a promotion and tenure perspective, who invites you to come speak and give grand rounds, et cetera, et cetera. And then the last thing is, what are the other interests that you have that you can turn into operational work? So again, sort of with the early interest in health disparities and health equity, that was some of the early writings that I had. As I've gone later on in my career, my partnerships now are more or less around emergency medicine, but I work with a number of other boards. I'm on the ACGME board, America's Essential Hospital Safety Net. So I do a lot of work with the Safety Net Hospital Association and some of our funding around there. So I think the key is keep partnerships, identify some early mentors, think outside the box in terms of who those partners could be, think about atypical funders, becoming a clinical expertise. And I will stop there and participate in the rest of the panel, and happy to answer questions.
Thank you so much. That was super rich and spoke to the need for partnership and collaboration, but also sponsorship in collaboration with a mentor, maybe. Josh, do you want to take it from here?
Sure. So I'm probably the junior member of this panel here in terms of career. I'm Josh Joseph. I am at Beth Israel Deaconess. I did an operations, not quite an operations fellowship, I did an informatics fellowship and now help teach our operations fellowship. So I came to this from a very quantitative background, and it was actually kind of being interested in systems. It was actually in the middle of like a computer engineering class where I was like, hey, the same way that we're making, these instructions and this processor run faster, we're kind of pipelining things. It was like, that seems a lot like how I do my workflow as an emergency physician. And that was actually what led me to operations, kind of thinking about, hey, here's this totally different field. Here's this way work gets done. This is actually very close to the work habits that we have. So for me, that ended up building into a project where I approached our operations director, Leon, who's on this call, and basically said, hey, I've got an idea. Let's look at this super complicated thing. We're going to do all of these moving parts. And he's like, no, slow it down. All right, let's answer some really basic questions first. Let's just say, is there good data about how many patients a physician, like a resident physician, sees per hour? We'll build into a big project someday. That sounds cool, but do the simple thing first. And that was kind of my foot in the door for the world of operations. It was a super brief study, but it got a fair amount of traction. And I just kept building and building and building because there were a lot of questions that just naturally came out of that. Okay, so residents see, maybe they don't see a single, average over the shift. Maybe there's kind of a dynamic over the course of the shift. But what happens when you factor in sign out? What happens when you talk about like overnight shifts or stacks of overnight shifts? So there were all of these questions, and that for me ended up being the kind of core of a career researching operations. And so I definitely came at this from a very kind of quantitative end, and later kind of moved on to become our operations research director, and now am the network director for operations for I think seven ED network at this point. So it's been kind of a gradual move into the administrative side of things. I'm still mostly on the research side, very big picture type questions. And in terms of really getting started, I mean, like, yes, it certainly helps to have a paper that people get excited about that will help launch things. But what it really is about early on, when you don't really have any footprint in operations, is really putting yourself out there. And it really can help to find a mentor or mentors who are kind of willing to let you get your feet wet, but also have a real plan for how, if things go well, you're going to move from doing lots of grunt work, not a lot of writing necessarily, or some writing, but not necessarily leading the direction of research, to making those gradual steps toward developing the next hypothesis, toward being able to see one or two papers down the line how you are going to start really building your interest to the point where you're doing this independently. And you know, it's hard, particularly when you don't have that established track record. If you're at your own academic department, you may find you're basically kind of trying to glom on to several different projects, and that's okay. A lot of them probably won't pan out, but I think the real trick is in transitioning from like year one, year two, where you're still putting out a lot of feelers, to really being able to make a judgment and say, okay, these are the one or two projects that really have legs and are really worthwhile to develop as my niche, as opposed to simply putting myself out in many different directions at once. Again, you're just getting started, you've got to put those feelers out there. But the minute you start getting traction, particularly if it's a project that interests you, as opposed to just a project that's out there to do, that's when you really need to jump in. And that for me was, you know, one paper that led to another paper, and then led to a talk, and then led to being able to have some kind of local, and then we'll say a little bit of national expertise about this one slice of this much bigger pie of operations. I definitely would echo a lot of what the other speakers have said, in that I think, you know, one of the big things that I wish I had done earlier is, in parallel with that particular operational interest, is develop a very specific clinical interest that worked with it. And that's partly because, in terms of grant funding, the federal government funds a lot of grants to look at diseases, to look at organ systems, to look at particular clinical issues. It's a lot harder to get funding to simply say, I want the emergency department to run faster and better. We all know, working as emergency physicians, if patients come back sooner, if we see them faster, generally the quality of their care is going to be better. There's all of these problems with delays. We all know that it's bad. Communicating that to the outside world is still, in 2021, like actually kind of hard to do. And there's not so much money out there simply for saying, we're just going to improve the quality. Now, again, if you can say we're going to improve the quality with which we're treating STEMI, we're going to bring down the amount of time, the door to balloon time, all these other quality markers, then you're in business. And you know, if you're still on the purely operations side of things, being able to take the QI angle, we're going to reduce the number of times where patients leave without being seen. There's still definitely some opportunities in that, but you have to really think strategically about how you're going to phrase things, as opposed to simply say, we're going to really grease the wheels, we're going to make things run better.
So diving a little bit deeper into that, I think one of the questions for a lot of the junior faculty members is, which specific QI or operations projects should you be trying to convert into something that's academically productive? Because I think there are a lot of small projects where we feel like we've accomplished something great within our department or even within our hospital, and somebody comes to us and says, you should really write that up. When is it the right time to do that? Or is it only when you've sort of done that prospectively? And we can start with Josh on that question.
Sure. I think that when you do that, you have to, one, again, it really helps if you've got some particular condition involved. If it's stroke, if it's heart attack, it could be something that seems like much smaller. It could be an orthopedic issue, but it helps when you can get that framing in terms of some medical problem that coexists with it. And I think the other big end of things is to look at the research literature a little bit. I mean, again, you don't have to do a huge deep dive, but to really understand if what you're dealing with is a local problem or more of a national problem. Again, I think we all have services in our hospitals that are a little bit tough to deal with. We all have like particular quirks about certain tests we want to get, or just conditions that we seem to have trouble with. And again, it's not like a personal thing, it's often just an institutional issue. And it can be very hard sometimes to see how, especially when you're very early in your career, what is a local issue that's important for you guys to fix as an emergency department, but what probably is not terribly interesting to a larger audience, and what is really a big picture question that, even though we're approaching this local version of the problem, is going to be of interest and really generalizable to other folks in operations.
Yeah, I would just piggyback and say, I think, so I completely agree. The short answer is yes, you should try and write up everything on some level. Now, the longer answer is, I think I would flip it and say, as you approach every operational and or quality question, approach it from the research perspective. Like, what is the question you're really trying to answer? It isn't just how quickly are people moving through the ED, or how fast are we giving thrombolytics or getting people to the cath lab, et cetera, et cetera. It's really, what is the research question you're trying to build around an operational question? So is it a flow question you want to answer? And then it gets to the point I think Josh just made around, it may end up being a local question, but it may end up being a bigger question as you think about what your partnerships are. So as you think about every operational initiative, think about it from a research perspective. And I would also say, depending upon your institution, also think about getting early IRB approval / waiver. That way, as you think through it, then if you think, okay, now we really can write this up, you've already cleared that hurdle. And many of these projects won't need, obviously, to go through the full IRB. Obviously, it depends upon your institution, and you should be able to get them waived if they're sort of under that QI umbrella. But I know at my previous institution, you couldn't go back and write it up. So it was always important to try and get that in on the prospective level.
Dr. Weiler, anything to add there?
Yeah, I agree with all of the comments. And I think I agree with the comment, try to write everything up. But I do think it's especially in this instructor, assistant professor to associate professor space, I'd go back to the comments I made before about being, deliberate where you're going to spend your time. And I feel like I hear a lot of write that case report up. Oh, you're in operations, write up that clinical case. And just to be clear, that's not anything that panelists are talking about. But what I would comment on is that where there is an opportunity, I don't see people see this as a space for scholarship, but I think it's important and definitely publishable. It's in process. So describing, how did you train your nursing staff? How did you set up a certain process? It's not just the outcomes, where absolutely traditional funders are disproportionately focused, especially in this disease state process. But there's actually a lot of journals that I think we don't think of outside of emergency medicine who are interested in process, engagement, teamwork, and especially in the nursing literature, they're great partners to us. And that can also be a space to show also your co-mentorship on an interdisciplinary or interprofessional team. So I would think about that as describing how you did it, not just what the outcome was.
In addition to the nursing journals, is it the quality journals, Joint Commission? Are there other specific examples you would share on that?
Yeah, I think those are all good. I'm going to jump in Josh's space, and I think this informatics space is really interesting. That's opening up, and then innovation has become sort of the catch-all for everything from do something quicker, faster, better to technology. And so that's also an interesting space that people don't look. And then I've had some success in the traditional non-healthcare operations space with partnerships of folks who are, in the school of business who are just traditionally math and operations focused. And so I think that's another space. If you had those it comes back to what Dr. Haley was saying, and that's deliberate partnerships. And then also this social determinants of health rural care space. Also, I mean, there are just a plethora of different journals focusing on specific patient populations where there's also an opportunity.
Great. So I want to pivot the conversation. Dr. Haley, this question is going to be for you to start. What are like the behavioral competencies of leaders that excel within the academic department space, maybe extended to the medical school versus on the health system side? Do you see a difference there, or is leadership and it's all coming back to patient care?
That's a great question. I think there's probably not as big a difference as you think from sort of the health system side, the academic to the College of Medicine side. I mean, obviously, as you think about leadership in the College of Medicine, it obviously has a more of an academic focus, and your primary goals are obviously to continue to grow the sort of the tripart mission of the academic enterprise. And so you want leadership skills that are focused on how are you going to grow your next set of academic clinicians or educators or researchers, but it's still around mentorship and providing, appropriate development for that group, having enough emotional intelligence to sort of guide people through their growth and development. I think those are important. Obviously, always being inquisitive, I think, is absolutely critical. On the health system side, the big picture system level thinking is really critical, thinking beyond what happens in the emergency department or on any given shift, thinking about what the impact is across the enterprise absolutely helps thinking. Put yourself in the shoes of sort of your other colleagues. One of the things somebody told me very early in my career was, if you want to get into health system leadership as an emergency physician, you have to stop thinking like an emergency physician, which is you have to put the hat on of your colleagues in, surgery or medicine or even primary care outside of the network, and how can you continue to work through those and see sort of healthcare from a different lens. So those are important from a health system perspective. So I think those are important. If you think about some of the other typical skills, communications is critical no matter which part of the bucket you are in. They're absolutely critical for faculty. How we communicate with faculty, so having a great communication skill set is important. How you communicate as an organization from a health system leadership perspective. I've got 8,000 employees that work for me that are scattered across 2 states and 5 counties. So you have to over communicate, right? And every time you think about, how you're addressing that is important. Humility, important across, both sets of those perspectives, and I think the other thing is understanding and knowing when you're wrong. Right. And being able to admit that and holding yourself accountable, so accountability is something we always talk about in healthcare, but holding yourself accountable is important. I think this goes back to something I think Dr. Weiler said about being deliberate and having your goals. So what are your goals as an academic leader? What are your goals as a system leader? And if we don't meet them, being able to own up to it and why didn't we meet them? But then also having the inquisitiveness to go back and figure out what are we going to do different to get to that goal, whatever the case may be, and how can I help lead? So those are just, I think, some of those things that can cross both spectrums, but maybe unique to each bucket.
Great. Dr. Weiler, anything to add about leadership competencies, differences you see as helpful on the school side versus the hospital or health system side?
I have a couple of thoughts. I would say being proactive, seeking out opportunities is an important leadership skill. As Dr. Haley has said, and I'll paraphrase a different way, being okay with failure, right? Putting yourself out there and trying things. Relationships are critically important. I agree. So being a team player. And I think that's what's actually really special about emergency medicine. Although the advice that I've also received is don't think like an emergency physician. The characteristic we shouldn't lose is that we know how to partner with everyone in the house of medicine. And so I think that's actually one part we shouldn't lose. Creativity and innovation and really around this problem solving and thinking in the microsystem, but as Dr. Haley said, scaling it broader, even if it's within, inpatient, outpatient, but even at the health system level. So really being able to, as I say, the 100,000 foot view to the 3 foot view, being able to scale in to the bedside and then from a system perspective is really important. And then grit. I think is, critically important as a leader. And then last is to ask questions. But where I see leaders fail actually, frankly, which is a characteristic of some of our peers in other specialties, it's the inability to make a decision. So it's ask questions, but also at times be decisive. And I think every characteristic I just described is one where many people in emergency medicine who have those characteristics choose this as a specialty. So I think that makes our specialty really well poised to take on leadership roles within our institutions, either academic institutions, healthcare delivery institutions, or actually health policy.
Thanks. Josh, I wonder if you could comment on, you commented on your system is now 9, who knows, maybe tomorrow will be 10 EDs. Dr. Haley commented on he's leading 2 hospitals, a 2-year medical school, and a huge physician practice. How is health system transformation changing what you focus on in your academic life?
Sure. I think there's certainly one sense in which, as a researcher, it does make a lot of things easier. I've had the luck of having very good access to data. It's been very clear about one hospital for the past 6 years. I now have pretty good data on 4 hospitals, and we'll probably have decent data on 7 hospitals. So from a very basic standpoint, that alone makes things a little bit easier in terms of being able to do research. In terms of actually being able to look at larger issues between hospitals, it's actually much more complicated and much harder because if you're looking at a process like transferring patients from who are orthopedic patients from one hospital to another within a system, you may have relatively easy to deal with standards from one hospital to another. One hospital may have much more of an appetite for those complicated hip fractures than another. But when you start talking about 7 different hospitals, which were not all planned, and this is the majority of multi-hospital systems out there, it's not as though there was one mothership and then it just kind of spread out, and the same culture from all of those hospitals went out to all of those different hospitals. As has been the case for many, many of these networks, these are mergers of various sorts between existing polities of people in different specialties with different standards and availability of nursing care and resources. So often the transfer from one hospital is completely different from the transfer from another. And kind of those standards can be very different, and getting everybody to talk about the same sort of process in the same way can be really hard. And that can be, again, where your hat as an emergency physician is really useful, because again, you understand in a fundamental way, and a lot of emergency physicians within our network, a lot of these other hospital networks, rotate between the hospitals far more than other personnel do. So again, I talked to an emergency physician who works at one of our hospitals, and they know what hip fracture gets admitted at one hospital as opposed to another, even though the orthopedists at those hospitals might not really see eye to eye or really see how things are moving in the same way.
Other thoughts, Drs. Weiler and Haley? Health system transformation, how that affects your academic life?
Sure, I'll go next. It obviously has a huge impact, but it depends on, as you've described, where you work, and even, what a health system looks like. Is it tightly integrated, or is it essentially confederated states? But I think having awareness, especially as a junior faculty, about how that plays into not only your research and scholarship, but ultimately your operational role is really important. And I think it can be leveraged as an opportunity. I think in large integrated health systems, it's harder to do tests of change. So for instance, in my CQO job, I'm spending a lot of time standing up essentially service lines, where now we have a governance model that requires 12 different hospitals to agree on a process, usually, right, in your medical record informatics space. So it's kind of hard to get something done there if you don't have a model where you may have influence, your mentor has influence. That said, if you're in a confederated state model, it actually may be the perfect place to do tests of change in this sort of step wedge design space. And then just to echo what Dr. Joseph said, these large integrated systems usually allow you access to data that we've never been able to see before. And so really, if you want to focus your scholarship on asking questions of the data, there's really an opportunity to do that was not available before. And so I think that's a space that is yet untouched in our specialty, to really ask questions from emergency medicine lens about what's current performance, which may inform where are there opportunities.
Yeah, and the last thing I would add to it, and I agree completely, particularly around the, bigger systems and having access to data and information, test to change. This is also sort of the follow the money question, right? So as healthcare systems are transforming, there's a lot of money floating out there to do different things. So, I mean, the telehealth, digital health, those are big, right? So think about what the potential applications are in emergency medicine and how can we piggyback that? And then think about who's funding that, right? And so there are foundations that are funding that. There's some federal dollars that are following that. So that's one of those, going back to something I originally said about sort of the atypical funders. A lot of space in health equity and health disparities right now, research, some at the NIH level. So think about operational initiatives that would impact health equity or health disparities that you could turn into a funding model. So think about, as you look at the health transformation space, think about what they're asking for change and think about who might be funding it to really support your work as well.
Great. With 3 minutes to go, just want to open it up to the group for questions, or my mentor and guide, Leon, any questions?
Yeah, one thing I was curious about is as you become more senior, what do you do to try to help your more junior people grow in operations and more importantly grow academically as well? Because we all know if you do ops and you don't have somebody that's looking out for you, the next problem will just eat up all your free available time. And I feel like you need somebody that kind of both sets space, but also kind of enforces goals so you get to where, to your maximum potential.
I think there's many ways to answer that. And I think you, as a mentor, you have to do a self-assessment and say, what is the value I can add to a mentee? And obviously it depends on who the mentee is. The way I am a mentor to a nurse is different than I may be as a mentor to, a medical student or my administrative fellow. But I think, again, back to our suggestions before around, really you need a mentorship team and to think sort of outside the box and how you do that, to either find partners who backfill where you have gaps, or for mentors to teach you where there's opportunities. I think you have to decide, is the mentorship you're going to provide one in the scholarship space? So is it access to data? Is it around research methodology, how to think about a question? Or is it on the sort of operator side, relationships, access to projects? There's a lot of great work that happens in the operation space. And back to the original reason of this panel, you spend your entire life delivering great care and creating great systems, but not having any time to write about it. And so that's an opportunity to partner with mentees where they get, scholarship, maybe fumes off of the work that you're doing. And that's really valuable for them to not only learn how to run an excellent fill in the blank process, but also how to think about the problem and describe it.
Yeah, the thing I would add, so in that mid-career point for me, it was around making sure I could find my successor. So I really wanted to figure out a couple of people in the department that I felt could take over as the leader of the department. And then I would follow in the operational footprint. And obviously they would be a collaborator, partner, help us write, think about new projects, think about new funders, those kinds of things. When I got to the next phase and kind of the dean role was around supporting department chairs, quite frankly, and thinking about how I needed to mentor them from a different perspective. And usually it was around helping them run their departments from an academic standpoint, but also increasingly from a financial standpoint. And then when I moved into the CEO role, one of the programs I created here, we created sort of two programs. One's called LEAP. It stands for Leadership, Excellence, Action, and Partnership. And we very specifically take, it's kind of basically our rising stars across the organization, hospital, the physician practice plan, the College of Medicine. And there's about 25 people, and it's around mentorship and a development program that's very specific to them that we developed. We have another one called STEP for some of our junior learners. So I've moved it from sort of the individual mentorship to kind of a chair level to really senior leaders across the enterprise. But I think when you make those leadership decisions, if you go into leadership, you have this sort of leadership competencies. One of the leadership competencies is always developing the next set of leaders, right? So making sure you're always developing your successor. I had somebody tell me relatively early in my career, as you get older, you should be spending 40% of your time mentoring or developing other people. I'm not sure I spend quite that much time doing it, but I'm very proactive and keep it on my calendar in a specific color to know how much time I'm spending in the leadership space.
All right, we're going to have to stop it there. This was a wonderful, rich discussion. I want to say thank you to Drs. Joseph, Haley, and Weiler, and a huge congratulations to Dr. Weiler on her tenure as full professor at the University of Colorado. Huge, huge accomplishment. Thank you so much for your time, and enjoy the rest of SAEM.
Thank you for the opportunity.